everyone. Today I'll be talking to you regarding pediatric diseases, primarily so-called congenital heart disease. Well, these are the diseases which start soon after the birth. Of course, they are present at the birth also, but they may manifest at different time. But thing is, many of these they continue in the adults also. So, in this today I'll be talking to you regarding left to right shunt mainly. But before that, the basic concept regarding that is fetal circulation. Okay, as far as fetal circulation is concerned, it is a big diagram. So I have broken down into two parts so that you can understand better. It was in fact big diagram was there. So let me show you one half of the fetal circulation. This is the placenta, and from placenta blood is going toward, and it is coming toward the placenta and going away from the placenta. Well, from where the blood is coming, it's coming from internal iliac artery, and this is bringing the blood toward the placenta, and the blood is going away from placenta via umbilical vein. That means you have to remember only two words: internal iliac artery and the umbilical vein. Okay, the two words. Point to be noted: the internal iliac artery is bringing deoxygenated blood to the placenta where the oxygenation will happen. Okay, and this oxygenated blood goes from placenta via umbilical vein. So this is the one exception, well, in the pediatric age group, that the vein is having more oxygen and the artery is less. And we also know that same thing happen in pulmonary circulation also in adults. In pulmonary veins, in adults, they have a oxygenated blood. So point to be noted, there are two exceptions. One is in the fetal circulation, and other is in adults is regarding where the veins have more oxygen than the artery. So friends, umbilical vein and internal iliac artery. Well, now this blood is coming from, of course, this blood is going toward the internal iliac artery. Now this oxygenated blood is coming from the umbilical veins. What happened? Look into this. So this blood goes into liver, but it has a bypass. It has a bypass, and the first bypass is ductus venosus. Note it down. It is bypassing the liver, okay, ductus venosus, and it is coming to the heart. Then we have of course, heart means right atrium. So from here the blood will go into right atrium. This is the right atrium. So first, this was the bypass. Second bypass, once the blood comes to the right atrium, okay, right atrium, it goes to the left atrium. That is via foramen ovale. We have a foramen ovale. And blood will go to the left atrium via from right atrium it goes to left atrium. This is foramen ovale. This second bypass. Well, so finally blood come from LA to LV, then it is supposed to go to aorta. Okay, well, some amount of blood come to the right ventricle also. Some amount of blood come to right ventricle. From right ventricle it enters the pulmonary circulation. Now this again we have a third bypass. Third bypass is that from the pulmonary artery, the blood enters the aorta. This is via ductus arteriosus. So we have a first bypass is ductus venosus. It is bypassing the liver. Second is foramen ovale. The right atrial blood goes to the left atrial, but some amount of blood does go to the right ventricle, again enter the pulmonary. But again it goes to aorta via ductus arteriosus. Net result is that very little amount of blood is going to the lungs. So we have three bypasses: ductus venosus, foramen ovale, and third is the ductus arteriosus. Right? So there are three shunts. So now I'll be showing you individual shunt. If somebody has not understood in the previous, with each individual focusing, your concept will be much better. So there are three important shunt as I mentioned. Now each shunt in more detail with closer outlook. First is umbilical vein. Yes, we studied that blood is coming from via umbilical vein, which is carrying oxygenated blood. It is conduct and via, now it is, instead of going into the liver via ductus venosus into the inferior vena cava, and inferior vena cava, it bypasses the hepatic circulation. So now you can write down umbilical vein goes to inferior vena cava, and this is via ductus venosus. Ductus venosus. So beautiful summary of the first bypass. This you can make a box. Now things are easy for you. So ultimately blood has come to inferior vena cava, and that everybody knows that is going to enter into right atrium. Yeah. So now the blood has come to the right atrium. Now from right atrium blood enters into left atrium. Now let me show you second bypass. Second bypass. Okay. The second bypass is, we have this bypass, blood has come and it is entering to the left atrium via foramen ovale. So friends, right atrium goes to left atrium, foramen ovale. So this is the second box to be remember where the shunting occurs. Now, so ultimately blood has come to the right atrium, it has gone to the left atrium, but some amount of blood does enter the right ventricle also. Point to be noted. Not everything goes to left atrium. Some amount of blood come to right atrium, and of course this will enter the pulmonary artery. Of course, the blood which has gone to left atrium will come to left ventricle. That will enter into the aorta. Agreed. So some amount of blood going to aorta, some going to pulmonary artery. From pulmonary artery again we have a shunt, patent ductus arteriosus. So from pulmonary artery blood enter the aorta, and this is by patent ductus arteriosus. In for ductus arteriosus, and this is blood is going from pulmonary artery into aorta. So net result is very little amount of blood goes to the lungs. So we have three shunting is there. I hope things are very, very clear to you. Well, with this background, we talk about, again, lovely diagram for your better understanding. Okay, so deoxygenated blood, it goes from right atria to right ventricle, then the main pulmonary artery, and it enter the patent ductus arteriosus. This go to descending aorta, shunt is due to high fetal artery resistance. Why this shunt occurs? Now come the question. Why this happens? Again go to the basics. Why that is not, why the blood is entering into the aorta from the pulmonary artery? Now come the golden line word to remember. This is due to very high fetal pulmonary arterial resistance. This is the only thing you got to remember. So friends, this is blood going from pulmonary artery into aorta because the very high resistance is there. Look, lungs, very high resistance is there. So that's why, and this is a open gate. So it's an open, very easily blood will flow. It's a rule. Wherever very rule is there, suppose water is there, and there's one like this and the one like this. We have a table like this, and this water glass is there, and this falls. Some water will here and some will come like this. Do I need to tell you where the maximum water flow will occur? Definitely here. Why? Is by the effect of gravity, it will go very fast. Very little amount of blood will go this side. Same thing, no resistance, blood can very easily go into aorta, and very little amount of blood will go because of high pulmonary vessel resistance. So a quick recap of what we have done so far. Umbilical vein enter into inferior vena cava via what? Ductus venosus. Blood from the right atrium goes to left atrium via foramen ovale. Blood from the pulmonary artery goes into aorta via ductus arteriosus. Next, why the blood doesn't go into pulmonary circulation in the intrauterine life? Because of high pulmonary vessel resistance. So there are only 4 key words to be remembered: ductus venosus, foramen ovale, ductus arteriosus, and very high pulmonary vascular resistance. That's all. With this background, now let me show you something more. Now, blood, we discussed pulmonary vein. They have about 30 millimeter mercury and is 80% is the saturation. Point to be noted, PO2 of umbilical vein is 30 millimeter mercury and it has a 80% saturation. Now the point what I mentioned to you in pulmonary, in case of umbilical vein which carries the oxygenated blood, note down how much PO2, 30 millimeter mercury, and how much saturation, 80% is the saturation, very high amount. And definitely umbilical artery will have a very low oxygen saturation. So you got to remember the word 30 and 80%, only 2 words to be remembered in this particular slide. And now you know the meaning. What I talked to you in the previous slide, the pulmonary vein has got, umbilical vein has lot of more oxygen. Now the 30 millimeter mercury and 80%. Well, so now we have seen after birth what happened. What happened to these ducts where after birth? What is the fate? What happened to these structure after birth? Let us see. We have a ductus arteriosus. Remember, what was this? It was uniting pulmonary artery with the aorta, and after that in the adult it is a ligamentum arteriosus. Ductus venosus, it becomes ligament venosus. Foramen ovale, this becomes fossa ovalis. Notochord become nucleus pulposus in the intervertebral disc, intervertebral disc. Umbilical artery, medial umbilical ligament, and umbilical vein, ligamentum teres hepatis. Okay. So these are the end. That means these are the structure which were there in the intrauterine life, and these are the structure which are in the adults. I like to talk to you regarding two structure here. If this duct doesn't close, if it remain patent, this will make patent ductus arteriosus in the adult. And if this foramen ovale doesn't close, and this is going to make atrial septal defect in the adults. The clinical applied of this table, which is really relevant, of course, they do ask question from anatomy, especially embryology. They do ask this question, very important question. What is the fate? Okay, and so now you are, and what the clinical applied is, ASD is foramen ovale and ductus arteriosus is patent ductus arteriosus. So before I proceed further, one thing, very important point what I mentioned in the umbilical circulation is very high pulmonary vascular resistance. So now let me show you. This slide is worth $1 million. So at birth, what is the physiology at birth and what is the physiology at adults? This I'll go deliberately, I'll go very slowly, and I like to repeat twice. This is the basic foundation of the entire congenital heart disease. So at birth, superior vena cava blood is coming, inferior vena cava blood is coming. Okay, and the pressure is 10 millimeter mercury. Pressure. Oh, from here the blood is coming via pulmonary veins, and it is 10. And we should not forget the blood is also coming via foramen ovale in the intrauterine life also. So what we notice, the pressure in the two atria is same, 10 and 10. Then let's see the pressure in the right ventricle, 60 by 10. Oh, 60 by 10 in left ventricle. That means the pressure in the two ventricle is also same. Let us see. Then we have, this is pulmonary artery. This is the aorta. The pressure in the pulmonary, oh, 60 by 40. Aorta 60 by 40. Oh, great. And we also know that they are united to each other via ductus arteriosus. And we also know that blood flows like this. Yeah, but pressure is same. So since the blood is flowing, so by and large, pressure, oh, pressure 10, 10, 60, 10, 60, 40, 60, 40. Exactly same. What is the reason behind that? The reason is this. Single most important line. Pulmonary vascular resistance. PVR is pulmonary. Vascular resistance is 250 units. 250 units. Note it down. What is unit? What is dyne? This I'm going to discuss when I discuss the pathophysiology. A quick recap. Both the atria, pressure is how much? 10. Both the ventricle, how much pressure? 60, 10. Aorta and pulmonary artery, 60, 40. We have a patent foramen ovale. We have a ductus arteriosus. Point to be noted in the normal intrauterine life. The connection is at the level of atria and at the level of aorta and the pulmonary artery. Point to be noted: there is no natural connection between the two ventricles. The natural connection in the intrauterine life is in the atria and in the big arteries. And the key factor what we learned is very high resistance, and that's the reason blood does not go into the lungs. Okay, yeah. So we are clear about this. Now let's talk about what happened in the adults. So in adults, blood is coming again. Yes, it is coming from the superior and inferior vena cava, and this is closed now. Remember, it was open in the intrauterine life. Pressure here is 0 to 6, 6 to 10. Sometimes they write 6 to 12 also. Here 25 by 0, 120 by 0, 0 to 6 or 0 to 10. And the pressure here is 25 by 10 and 120 by 70. Point to be noted. Now the left-sided pressure are more than, look, this is more, this is more, this is more. So we are getting more pressure on the left side as compared to right side. 0, 6, 6, 10, 25, 0, 120, 0, 25, 10 and 120, 75. Why? Now the pulmonary vascular resistance is 1 to 2 units. Point to be noted that here the pulmonary vascular resistance are 250 unit. Now it is only 1 to 2 units. You can compare, you can see the bigger picture now. Yeah, I hope you could see it. So the one thing which we learned today, something new, the basic concept is that in one major difference in the intrauterine life and in the adult life is a pulmonary vascular resistance. Due to high resistance, blood doesn't go into the lungs, and God is the greatest engineer. This oxygenation is done by the umbilicus. Okay, why umbilicus? Because this blood, oxygen come, blood come, every nutrient come from the umbilicus. Now look, see the beauty of the God, how he has made. This is mother, this is the placenta, and this is the fetus. From mother, every nutrient, oxygen come to the placenta, to the fetus, and every waste goes down. Nutrient, including oxygen, and all the body waste, they go like this. Lovely, normal. So God knows, God created our body in such a, I always say, God is the greatest engineer. So even oxygenation is coming from the mother only. So now lungs have no special extra purpose. Lungs are not, of course, they are developing, but non-functioning. Only little amount of blood goes to the lungs. Agreed. So having learned this basic, we understood the key factor is pulmonary vascular resistance is increased. I'll come back to this slide once again, but you have noted it down, the figure that I'll be needing later once again. Now, changes occurring soon after birth, a good amount of thing we learned. Let's see. So once the birth, the infant takes a breath. Yes, we know, we all have done posting in the labor room, or if not, at least we have seen maybe picture also, that when the child is born, he cries, yes, and he start taking breath. So now there is a reduction in the resistance in pulmonary vasculature. Look, the moment child is born and the moment umbilical cord is cut, That means the source of oxygen is gone. Mother oxygen is not coming because umbilical has been caught and tied also. Now God is the greatest engineer. He already has made the lungs fully developed but non-functioning. Now when the child cries, the child needs oxygen. There's no source from the mother. Now automatically the resistance in the pulmonary vascular get reduced. How much was it? 250. And adults is 1 to 2. Okay, of course it will not come to 1 to 2 immediately, but it start getting down. So with the result, definitely now blood, more and more blood will go to the pulmonary circulation. Definitely more blood will enter the lung. From the lungs, more blood will come to left atrial. That causes increased left atrial pressure. You can write down. More blood goes to lungs. More blood goes to lungs. Now increase LA pressure occurs. Definitely more and more blood is coming, increase LA pressure occurs. So LA pressure become more than the right atrial pressure. So well, what will happen? Look into this. This is the atrium. This was the foramen ovale. Okay, foramen ovale is there. The blood was coming like this from RA to LA. Okay, in the intrauterine life. But now the LA pressure increases. It will close this. It will close this because LA pressure, so it become close. The foramen ovale get closed because of high pressure in the left atrium. And as I told you, once that close, this is called as fossa ovalis, the point I mentioned to you. The fossa, it is the foramen ovale which makes the fossa ovalis. Yeah. So we understood why this is closed, and now we also know why LA pressure is more than the RA pressure. Okay. Okay. So what happened? Now there is increased oxygen in the left atrium. Why? Now the blood is coming directly from the lungs. So we have a more oxygen in the left atrium. Prostaglandin level get reduced because once the placenta gets separated, the cord is closed, the prostaglandin level get close. This reduced prostaglandin lead to the closure of the ductus arteriosus. It means what? During the intrauterine life, duct has to be patent, and that is being done by the increased prostaglandins coming from the mother circulation into the fetus, and PDA is maintained, and once this is get closed, the umbilical get cord cut, the prostaglandins goes down, and that lead to closure of the ductus arteriosus. It means what? Which of the following molecule maintains the patency of ductus arteriosus in the intrauterine life? Prostaglandins. Okay. So suppose in some cases the ductus remain patent after birth. We use indomethacin. This helps to close the PDA. Why? Why? We all know very well the non-steroidal anti-inflammatory drug. They are anti-prostaglandins. Classically, they use indomethacin, and ultimately the ducts close. And what is the remnant? Ligament arteriosus. Point to be noticed. It is the prostaglandins which maintain the PDA. So mnemonic is prostaglandin E1 and E2. They keep PDA open. Point to remember which prostaglandin, E, 1E, 2, 1E, 2E, they keep PDA open to the pneumonic. So I hope your fetal circulation is crystal clear and you can very well appreciate what happened in the intrauterine life and what happened in the extrauterine life of or adults, why the pressure differences are there, and they are the basic of the ASD, VSD, PDA and all other things that we are going to discuss just now. So one part is over, is the fetal circulation. So when we talk about congenital heart disease, very obvious, I don't need to tell you that these are the congenital heart disease, means that the child is born with this problem. It is there at birth. Point to be noted that it is there at birth, but it is not necessarily that it will manifest soon after birth. Manifestation may be at different stage. Okay. So now let us see these. We are talking about congenital heart diseases, but they may have some association is there. So let's learn some association. Williams disease, Williams syndrome. In this there is supravalvular aortic stenosis. This is the most important. There may be pulmonary stenosis, there may be hypertension, and there may be hypercalcemia. This is Williams. It's Williams syndrome. The Williams syndrome, remember, supravalvular aortic stenosis is the single most important. Down syndrome, very commonly asked question throughout the world. AV canal defect, perimembranous VSD. What is this? I'm going to discuss a little later on. And patient even can have tetralogy of Fallot. Okay. Turner, very commonly bicuspid aortic valve or coarctation. This is very, very important. In fact, bicuspid aortic valve is often associated with coarctation of aorta. Noonan syndrome, pulmonary stenosis, cannot afford to forget. This is the most commonly asked. Otherwise, HOCM, uncommon, ASD, uncommon. So don't forget APS. Holt-Oram syndrome, ASD with bone abnormality. Friends, don't forget Holt-Oram syndrome, Noonan and pulmonary stenosis, Turner bicuspid and coarctation. Don't forget. Don't forget these. Okay. Then the Down syndrome, VSD, supravalvular is supravalvular AS in Williams syndrome. Don't forget this. Very commonly asked questions. Well, we saw some of the association with congenital heart disease, but sometime prenatal exposure to certain medical condition or infection can also lead to congenital heart disease. This is again a very, very important slide. Gestational diabetes. Okay, so what are the problems that can a child born to the newborn child born to the diabetic mother? Transposition of the great vessel. Write down transposition of the great vessels. Atrioventricular septal defect, hypoplastic left heart, cardiomyopathy and PDAs. This can happen to the newborn child, to a diabetic mother. Rubella, one of the most favorite question of all the examiners. I think out of the two previous slide and this slide, this is one of the most commonly asked question. PDA, peripheral pulmonary stenosis and VSD. Okay. Point to be noted, golden line to remember, it is the peripheral pulmonary stenosis. But in the books they usually write as pulmonary stenosis. So problem is not at the level of valve, it is slightly away from the valve. Lupus, congenital heart block, very, very important. And whenever we have this problem, invariably they will ask you this patient, this complete heart block is common in those patients where the mother has RO antibodies. So these antibodies are, when they are there, they are connected with complete heart block. The child will be born with the complete heart block. Phenylketonuria, VSG, tetralogy of phthalate, PDA, single ventricle, plenty of problem can be there. But for exam point of view, very important. These two are very important. Can't afford to forget. So these were all the basic concept. Now we have understood what the congenital heart diseases are. Okay, let's see how we really classify. Classification is done based on the hemodynamics. Okay, what is this? We broadly classify all the congenital heart disease into two. Broadly, cyanotic or acyanotic. Cyanotic means the child is blue. Blue means cyanosis. This child is not blue, or medically we say no cyanosis. So that's why you call it cyanotic congenital heart disease and acyanotic congenital heart disease. Both have different type of hemodynamics. Okay. Not only that, there are certain other diseases which don't fit into this category. Okay, what are those? Like coarctation of aorta, okay, there's one category, and there are a few more that I'll be discussing in the coming slides. By and large, broadly, this is the most commonly discussed and asked. But don't forget, there are certain obstructive conditions also, like coarctation. So now I'll be talking to you regarding left to right shunt, which we call as acyanotic heart disease. ASD, VSD and PDA, they are the three classical diseases which are included in this category, so-called acyanotic and in acyanotic also we further classify into two. This point is not known to most of students. We classify as pre-tricuspid and we classify these two as post-tricuspid. So in the pre-cuspid we have only one major is ASD. In the post-tricuspid is PDA, and VSD is post-tricuspid, and the pre-tricuspid is ASD. With this, and second thing what I was talking to regarding acyanotic heart disease with obstruction, pulmonary artery stenosis, okay, HOCM and coarctation of aorta. These are the obstructive. I give you example of coarctation, but pulmonary stenosis, and there can be subaortic. This we classify into the category of obstruction because there is actually some obstruction to blood flow occurs. Okay. Cyanotic heart disease, we have second category. I told you one was the acyanotic. Cyanotic category, what we know, patient has cyanosis. What is the basic reason behind it? Definitely, the blood is not going to the lung. The basic pathophysiology is reduced pulmonary blood flow. The amount of blood going to lungs is reduced. So definitely no blood going to lung. That will lead to cyanosis. The example are tetralogy of phthalate, Epstein anomaly, total anomalous venous pulmonary venous connection or return, transposition of the great arteries TGA, what they write as, truncus arteriosus TA, and hypoplastic left heart syndrome. So we have a tetralogy Epstein anomaly, total anomalous pulmonary venous connection or return. Normally they write as connection or return TAPVC. The short form that we talk about. All these cyanosis, they have a cyanosis. So before I really go into these two categories of the diseases, you got to know a lot of physics, not even I can say physics also. So I'll take you to your school days when we all used to read physics, chemistry and biology, and most of us when we appear for our MBBS entrance exam, these three subjects, physics, chemistry and biology. So let me take you to the physics classes. So we'll talk about physics and physiology of blood flow and resistance. And just to remind you, I told you one thing, that in case of intrauterine life, there was pulmonary vascular resistance of 250 unit. I also told you that after the birth in the adults, pulmonary vascular resistance is 1 to 2 units. And that's a major difference in the fetal circulation and the adult circulation. So let's see what is this. So in physics, we are taught that in Poisson's law, okay, pressure is equal to flow into resistance. This is physics. Of course, when we are talking about a human being, so I don't need to say that we are talking about blood flow in the vessel. Of course, in the physics, they talk about in the flow in the tubes, etc., etc. We are not concerned with that. We are concerned with blood flow. So it means blood pressure in the circulation, any circulation will be flow into resistance. Pressure equal to flow into resistance in any blood vessel. So there are only two major factors. So now, suppose there is one condition where the flow is increased, resistance is same, pressure will increase, definitely, one component increase. Second is, flow is normal, resistance has increased, pressure will increase, definitely, no need to say. And if both are increased, the pressure will be very, very high. Very simple. So friends, we learn that two things are going to govern the pressure in the body, human body, flow into resistance. And now pressure is measured in millimeter of mercury. This is millimeter mercury. Flow is in liters per minute. Flow in liter per minute. Resistance, this is measured in dynes per second. Okay, or units. That means 80 dynes, they make 1 unit. Now you go back. What we learned, that in case of adults, the pressure is 1 to 2 units in the resistance in the pulmonary vasculature. Let's take 1. That means in adult it is 80 dynes. But in fetus it is 250 units. So this becomes 80 into 250. Oh, you can say it is this much dynes is there. Very high resistance is there. So to conclude in this particular slide of physics, pressure is equal to flow into resistance. So with this background, if I have to talk about systemic pressure, systemic flow and peripheral vascular resistance, pulmonary artery pressure, pulmonary flow and pulmonary vascular resistance. Very simple. Flow resistance, systemic and pulmonary artery. So we will be using these values little later on. So net result, as I told you, the pressure in a vessel depends on two things, flow and the resistance. Yeah. This is the pressure. So now, as I told you, so if the pressure increases, maybe due to increased flow or maybe increased resistance, which I showed you in the previous slide, via which any one factor increases, pressure will increase. Two increases, pressure will go very, very high. So pressure will be increased if increase in flow or increase in resistance. Now come the gold medal question. In left to right shunt, pressure may increase due to increased flow. Increased flow occurs in left to right shunt. Okay. Point to be noted, in left to right shunt, repeating second time, pressure will increase due to increased blood flow. Yeah. Well, and the left to right shunt include what? ASD, VSD and PD. So when now again, before I really go into forward, let me tell you some basic concept. This is the heart. Here is the VSD. Here is the ASD. Pressure here is 0 to 4. Pressure here is 4 to 8 or 4 to 12, whatever you can say. In ASD, this is the tricuspid valve. The problem is before the tricuspid valve. That's why ASD is also known as pre-tricuspid. The problem is pre-tricuspid, before the tricuspid. So now in the adult, pressure is slightly more in the left atrium as compared to right atrium. Point to be noted, recall that in the intrauterine life, the pressure was same in both the atria, but not in adults. The blood will flow very slowly from the left atrium to right atrium in ASD. Why slowly? Because the pressure gradient is very low. The blood will flow very slowly from LA to RA. And this will lead to what? No shunt murmur. No shunt murmur. Okay. But the even more than this, which is the most important finding when we do the catheterization study, is this. That is, this right atrium, it is getting oxygenated blood from left atrium. So it is, look again, now this point what I'm going to tell you just now is again worth $1 million. This you have to understand very clearly. Very, very important point is this. What is that? Yeah. This is the normal heart. Blood is coming to the right atrium via superior vena cava, inferior vena cava. These two are carrying deoxygenated blood. So I am writing DO. DO stands for deoxygenated blood. Same, this will go to, definitely same will go to the right ventricle also. No need to say. Same will go to the pulmonary artery. DO, deoxygenated blood. So when you are doing the catheterization study, you will find oxygen level of these three places is almost same, not much change. But now in the ASD, when you are getting oxygenated blood, suddenly now you take a sample in superior vena cava, blood sample, or maybe inferior vena cava, we are getting deoxygenated blood. But now you take a sample in the right atrium, suddenly you find this increased oxygen has come. The oxygen content of the right atrial blood has gone high. Where can there be, which condition can lead to this? Is ASD. So friends, golden line to remember, in ASD, there will be increased oxygen in the right atrial blood, increased oxygen in the right ventricle. Remember, same oxygenated blood is coming to the right ventricle. Increased oxygen content in pulmonary artery. Golden line to remember. Right? Agreed? So we are getting like this. Well, additional finding is that, and this blood is coming, now remember the large amount of blood is coming into the right atrium throughout the cardiac cycle, and this large amount of blood will flow from right atrial to right ventricle. Point to be noted, the excess amount of this blood is coming from RA to RV, and you will be getting a flow murmur. You might get a flow murmur at the level of tricuspid valve. Although there is no pathology in the tricuspid valve, but large amount of blood is flowing, you may get some murmur. Now this large amount of blood will be entering into the pulmonary artery. Large amount of blood. So there might be any flow murmur at the level of pulmonary valve also. The flow murmur may be there in the level of tricuspid valve. There may be flow murmur at the level of pulmonary valve. Agreed? Flow murmur. Large amount of blood is flowing. Large amount of blood is coming to the lungs. So there will be increased blood flow to lungs. And do I need to tell you the increased flow will lead to what? It can lead to pulmonary arterial hypertension? Yes, it can. So, and now we understood the meaning that in left to right shunt, the PAH will occur due to increased blood flow. Let us see what happened in VSD. Fresh diagram. Heart, tricuspid valve, VSD, the gap is here. Point to be noted, this gap is after the tricuspid valve. That's why I said we have a post tricuspid problem. Let us see. Pressure here is 25/0. Pressure here is 120/0. It was 0 to 6, 0 to 10. But again, for easy calculation, I am taking 25/0 and 120/0. Here the pressure in systole is 120. The pressure here is 25. So what will happen? During systole, a large amount of blood will flow from LV to RV. But this is happening in systole when the blood is also going out from the right ventricle into the pulmonary artery in systole. So large amount of blood is pushed into the pulmonary artery. So again, large amount of blood will go to the lungs. Increase blood flow. Remember, same thing happened in ASD. But that the problem was pre-tricuspid. It is post-tricuspid. So the large amount of blood will come back from the pulmonary artery come to the left atrium, and from left atrium large amount of blood will flow into the LV from the mitral valve. So we expect a diastolic flow murmur at the level of mitral valve. Just to remind you that in ASD we get diastolic murmur at the level of tricuspid valve. That's why I said it's a pre-tricuspid. Well, flow murmur will happen. What happened in ASD, the pulmonary artery will happen here also. But what is significance, I'll be talking later on. Now, here the blood is coming with a great pressure. So it can have a jet phenomena effect. It just strike the right ventricle wall with a great pressure. So it can have jet phenomena that can lead to endocarditis. Remember, in ASD the blood came very quietly, so there is no jet phenomena. In ASD. So in ASD endocarditis is not common. But what is more important, if you do the catheterization study in VSD, catheterization study, tricuspid valve, VSD. So this is the inferior vena cava, superior vena cava, you take oxygen. It is deoxygenated. Here also we get oxygen deoxygenated, same. But here if you take sample, it is oxygenated. The point to be noted here, the oxygen content of the right ventricle increases suddenly. From where it is coming? From the left ventricle. There is no source. So difference between ASD and VSD. In ASD there was increase oxygen. Okay, increase so in ASD oxygen in pulmonary artery. Here, increase oxygen in the left ventricle, in the right ventricle and pulmonary artery. But in right atrium, oxygen content will be same as venous. But oxygen content will suddenly increase in the right ventricle and the pulmonary artery. Okay, so increased blood flow, PAH can occur. Now let's talk about PDA. PDA is this is a pulmonary artery aorta 120, 80 and 25/10. This is the scenario. Well, in PDA 120, 25 in systole, blood will go from aorta to in the pulmonary artery in systole, throughout systole. Diastolic 80 and 10. Oh, it will go in diastole also. So we will be getting continuous murmur. Point to be noted that in PDA, there is a continuous murmur is there, and jet phenomena will be there. Endocarditis will be there. And now if you check the oxygen content will be increased only in pulmonary artery. the oxygen content in this will be reduced. It will be same as venous, and they suddenly increase the oxygen content of the aorta, of the pulmonary artery. Friend, this is the most accurate way to assess these three conditions. So now I give you a lovely, beautiful chart. ASD, VSD, PDA, shunt murmur. No. Pan-systolic murmur. PSM stands for pan-systolic murmur. This is continuous. Endocarditis. No. Yes. Yes. Oxygen, increase oxygen. Right atrium, right ventricle, pulmonary artery. Right ventricle, pulmonary artery, pulmonary artery. Beautiful summary of this. Increase blood flow, increase pulmonary blood flow. Yes, yes, yes. Increased pulmonary blood flow will occur in all the three conditions, which eventually can lead to pulmonary arterial hypertension. So I hope they're all basic concepts which I am talking to you. With this background, now I'll be talking in collectively regarding, so we understood increase in blood flow in the pulmonary circulation. We understood very nicely, including the shunt murmur and the endocarditis. So now I'll be talking these three in combined left to right shunt. So generally, when this blood flow, increase in blood flow occurs, it lead to PAH. PAH is pulmonary arterial hypertension. But it doesn't increase suddenly. Why? Why it doesn't occur so suddenly? It just usually occurs little later stage of the life, not in the early infancy. The reason being, what the reason? The reason is that pulmonary artery have a distensibility. Oh, it can distend, and it can accommodate 3 times the blood flow. Oh, let me give you a diagram. Here is the blood. This is the pulmonary artery, or in the pulmonary circulation also. So these vessels, pulmonary circulation can accommodate up to 3 times of the blood flow. So definitely it can accommodate. It has a distensibility. Distensibility is there, so it can expand, it can accommodate, pressure will not increase. Okay, so it can normal flow without increase in pressure because it can distend. Agreed. So what happened? Even the shunt is large, pressure will not increase because pulmonary artery can expand. Agreed. Now, in some situation, if the pulmonary vascular resistance is very, very high, now remember, now we are talking, remember, the pressure is equal to flow into resistance. So in left to right shunt, it was increase in flow. Increased flow was there, but it could very easily was taken care by the distensibility of the pulmonary artery. Now second scenario, where the flow is normal, but resistance is increased. The pressure will increase, definitely. Why? So let's see what the effect of resistance. So once we talk about pulmonary vascular resistance, it means obstruction in the pulmonary circuit. Obstruction is there, okay? So they lead to now what happened anatomically, what happened pathologically, that pulmonary vessel develop medial hypertrophy. Medial hypertrophy will happen, and later on even intimal changes might occur. If you go into the structure of any artery, in the artery we have a intima, media and adventitia. So when there's increased resistance is there, first of all media is involved, and later on even intima may be there, okay? So ultimately obstruction to flow is there, so that will lead to what? Increased pressure. Increased pressure will be there, develop very fast, and this hypertrophy is usually irreversible, okay? So friend, there is one more problem, one more pathophysiology, that there can be increased resistance which can lead to increased flow. Let me give you example. You are going on a road, okay? You are going on a road. Quite possible that you are going in a highway and you are going for a picnic, and there's a big picnic spot here. Picnic spot is there. Normally very few people go on the weekdays, okay, very weekly, but now weekend is there. This is a weekday flow, weekday traffic. Now weekend, holiday, large number of vehicles are coming, and this is a big road. Big road is there. It can accommodate any amount of vehicle because it's a big road. Well, it can accommodate more. But a stage will come when, okay, despite large, very heavy rush is there, now, jam is there. Now this road cannot accommodate more vehicle. But remember, this occur after a long time. Agreed? So now congestion will happen only after a long time. Second scenario, same road is there, same road, picnic spot, and there's some repair work is going on. Repair work is going on the road. Now the road is like this. Even the normal days, vehicle are going, but they are not very going comfortably. In the vacations, huge comes, cannot go. So very soon this traffic jam will be there. Remember, here this road is slow, here the volume is very high, but of course congestion did happen, but later stage. Here congestion occur in the very early stage. So what I want to convey the message is that pressure is flow into resistance. Increased flow will lead to PAH, but at a later stage. This is what happened in left to right shunt. Increased resistance occur in so many conditions which I am going to discuss later on, especially the right to left shunt. The PAH occurs very fast, and what happened, this I am going to discuss later on. But as of now, my focus is mainly on the left to right shunt. So you know, PAH will happen. PAH is pulmonary arterial hypertension, but in the later stage, not very early. With this background, we move further. So we are getting increase in pressure in the pulmonary artery associated with, Now we call as, remember, resistance is normal. In this, there is in left to right shunt. Resistance, left to right shunt, resistance is normal. Problem was increased flow. So we call as normal resistance, we call as hyperkinetic pulmonary arterial hypertension. So PAH is occurring due to hyperkinetic, means increased blood flow. Increased blood flow. So normal resistance, increased blood flow, what I've been talking to you. Okay, pressure is equal to increased flow into resistance. This is so-called hyperkinetic. Hyperkinetic pulmonary arterial hypertension. Now, if the pressure is due to increased resistance, we call as obstructive pulmonary arterial hypertension. So, if this is the scenario, flow into resistance, this will be causing as obstructive type of PAH. The problem of flow is hyperkinetic, problem of the resistance is obstructive. Okay. Can we distinguish between the two? Yes, we can. Let us see. Okay, what and how we do this, I'm going to discuss little later on. So now pre-tricuspid versus post-tricuspid shunt. I hope now you are, again this term most of you are listening for the first time. There's something called, we have been talking about left to right shunt from very early, maybe in the first year of MBBS also we are taught. But now today we got additional word, pre and post tricuspid shunt. Okay. So, and we also learned that in pre-tricuspid and post-tricuspid, what was the difference in the oxygenation? Okay. So now we'll be talking about ASD. Okay, ASD. So we learned the basic. And we are going to have increased flow. We are going to have hyperkinetic type of PAH in all the left to right shunt. With this background, we talk one by one, ASD, VSD and PDA. Few things I told you, few things are new. Little bit of overlapping may be there because that was essential to tell you the basic concept, which is not clear to most of students. Well, ASD, most common type is ostium secundum. Okay. This is due to problem in the fossa ovalis. Do I need to tell you what is fossa ovalis? No way. Remember, recall, in the embryonic life, we had a, this was the foramen ovale, and it got closed soon after birth. Okay, foramen ovale, and that made the fossa ovalis. But if this persists, this is going to make septum secundum. Okay, agreed. And it is usually asymptomatic in children. Point to be noted. And later on, as a child grows, maybe older child, symptoms start in older child. Okay, what will happen? Congestive heart failure. Congestive heart failure, why? Because of secondary to pulmonary hypertension. Why? Increased blood flow. Increased blood flow into the right atrium, right ventricle and the pulmonary artery, increased flow, so-called what? Hyperkinetic. And there may be atrial arrhythmias. Why? Because there is right atrial enlargement. Why right atria get enlarged? It is getting double the blood. Right atria will get enlarged, double the amount of blood. Blood is coming from the superior vena cava, inferior vena cava, as well as the left atrium. The right atrium is getting blood from the three places: superior vena cava, inferior vena cava, and right atrium, and that lead to left right atrial enlargement is a feature. Then we have a ostium primum defect also. Okay, this is due to endocardial cushion defect, and due to endocardial cushion defect, they are not able to make the septum. The point to be noted, the secondum was due to persistent fossa ovalis. Primum one is due to endocardial cushion defect, and we all know in the embryology, endocardial cushion is there that make the septum. Okay, this cushion is there, and that is going to grow and make. That is going to make the septum. This is not properly made. So invariably they'll talk in the exam, they'll talk nothing. Endocardial cushion defect. If this word is coming, you are dealing with septum primum. Well, but what is most commonly asked question? This is uncommon. The primum defect is 20 to 30%. Secondum defect is about 70 to 80%. Primum is about 20 to 30%. It's far less common. But what question they ask you? The question will be that patient, there is one blah blah blah, and they diagnose ASD. They will give you a lot of finding. In the finding, the classical word will be oxygenation. Increase oxygenation in RA, RV, and pulmonary artery. So this finding you are getting, fair enough. This is ASD. Now the question will be how to confirm whether it is the left sided or the right or primum or secondum. This is done by ECG. In secondum, you get right axis deviation. In primum, you do left axis deviation. This is the universal question asked in all the exam. Simple, look for the axis, and left axis is primum and the right axis deviation is the secondum one. Okay, now primum defect, it may be having associated condition like mitral valve prolapse or maybe mitral regurgitation. Mitral regurgitation may be there. It's quite possible that they have associated problem. MR may be there. And these primum defect is very commonly associated with Down syndrome, which is trisomy 21. So remember, usual they write is endocardial cushion defect. Is often associated with septum primum. This I gave you, but I gave you the list, the congenital association. Okay. Now this primum one, it presents earlier. Point to be noted, secondum one was presented, it presented later in the older children or maybe young adult. This is in the very early stage. Again, dyspnea, recurrent chest infection or pulmonary hypertension, and even they may develop very early cyanosis or early PAH. Now I like to talk to you regarding recurrent chest infection. This is a feature of all left to right shunt. All. Reason. How much is the blood flow? Blood flow is increase in all left to right shunt. We had understood. So large amount of blood is going into the lungs in any left to right shunt. So there is excess of blood, and if you do chest x-ray, in chest x-ray there will be plethoric lungs field. Plethoric lung fields means when you take x-ray, all the blood vessels are full of blood. So you get a very plethoric type. The typical word they use is plethoric type of lung. An excess of blood in the lungs predisposed to recurrent chest infection. Got it? So now I don't have to repeat that. Same thing will happen in VSD, PDA, that plethoric lung field and recurrent chest infection. Now I also told you that in ASD, PAH occurs especially. Now one more thing, whenever they talk of ASD, if not specified, it is understood that they are talking about secondum variety. In fact, I tell you in the exam, if they are to ask primum, either they will talk about Down syndrome, or they will talk about left axis deviation, or early PAH, or endocardial Cushing defect. I repeat again. Whenever they will talk about primum, either Down syndrome or left axis deviation. Third is early PAH. These are the three things what is going to ask if they talk about endocardial Cushing defect. Otherwise, no mention, it is secondum. So in secondum, this PAH occurs much later. Why? Let's learn the basic. When the child is born, there is stiffness of the two ventricles. Yes, when the child is born, both the ventricles are very stiff. That's why all the pressure were normal in the atria level and the ventricle level. Yeah. Go back to basics. ASD, ventricle at birth, stiff. Both are stiff. Blood is coming, yes, but this cannot come very easily. Why? This is not very distensible. In the very early stages, it's a stiff lung. So that means less amount of blood will come. There's no space. This flow is although the gap is there, but transmission of the blood is not very much. Why? There's no place, distance, less distensibility. So that's why when the less blood will come in the initial stage, less blood will go into the pulmonary artery. So for the first 2-3 years, same distensibility. Later on, blood will start going, and we know that pulmonary artery is very distensible. It will accommodate. And once the accommodation fails, then the PAH occurs. This is the reason that these children do not have problem in the early infancy. Okay, so that's why in ASD they hardly they manifest in the early childhood. So now we understood the clinical sign. They tell you the pathophysiology of the pre-tricuspid, and we also know that large amount of blood will flow from RA to LV, and we may get a diastolic murmur in the level of tricuspid valve. But this again will come in the later stage. It will not be there in the early infancy. Well, now what happened? Blood is coming to the left ventricle, or from right ventricle, from right atrium. The amount of blood coming to this, of course, I'm talking about older children or in the adults, okay? Amount of blood coming to right atria will be same in both inspiration and expiration. What do you mean by this? Normally, in a normal person, the amount of blood coming into the right atrium is increase on inspiration. It is reduced on expiration. In the left atrium, it is decrease in inspiration and increase in expiration. Reverse happen in left atrium. So that's why in a normal person, when the person take a deep inspiration, A2 P2 interval increases in inspiration. A2 P2 gap is reduced in expiration. This is normal. Okay? Normal. But here, whether it is inspiration or expiration, amount of blood coming to this is same. During inspiration, more blood comes. During expiration, more blood come here, but this again comes here. So respiratory will not have any problem. Same large amount of blood is coming to this. Large amount of blood will be going to the pulmonary artery. So every time A2 will come first and P2 will come very late. And that's a basic mechanism. That's why we get wide and fixed split of the second heart sound. There's only one condition where we have wide and fixed A2. If you get this line, this word, then 99.9999% you are dealing with ASD. Wide and fixed S2 is ASD. Golden line to remember. Okay. Well, pH occurs very late, the point I mentioned to you. pH is a late feature. Well, ultimate treatment of all this, when the patient has heart failure, so in the medically, if the patient has congestive heart failure, you treat by giving diuretics, and we may give digoxin in some cases if needed, but we try to maintain by diuretic. Finally, we do surgery. It performed during the first decade of life. Even in the absence of symptom, get it operated. Patient and believe these are the usually diagnosed incidentally. Patient has no symptom, patient has gone for some other illness, and some good physician may pick up any murmur and they investigate ASD is there. Okay. So you advise the patient to go for surgery. Doctor, patient doesn't have, the patient attendant will say he doesn't have any problem. But you advise why? To avoid later on, patient may develop right ventricle failure, endocarditis, and emboli. Embolism can occur. A left-sided embolus can go into right side. So you have to tell that you should ultimate it today or tomorrow or after 1 year or 10 years. Today patient child age is 10 years, and in due course of time he are bound to have problem. Maybe at the age of 25 years he will have a lot of problem. So better to take right. So this is the ideal example of prevention is better than the cure. So you want to prevent the problem, so better okay. So and better to get cured. So remember, here we are curing to prevent the complications. Agreed? And adults, again, even patient has symptoms, okay, you have to do it by all means to avoid the complication. So we are clear about ASD. The key word is wide and fixed second sound. Post tricuspid shunt, your concepts are clear. We are VSD and PDA. And what type of VSD we have? So let's talk about basic pathology. It is in the membrane or maybe in the musculature. Okay. Well, let's go into basic. This is the left interventricular septum. This part is muscular and some is the membranous. Problem 70 to 80% problem occur in the membrane, and 20 to 30% or 10% occurs in the 70 to 80, 90%, and about 10 to 20% occurs in the muscular part. Okay, more of that means it is the membranous part is membrane more as compared to musculature. Well, now here let's talk about VSD. Blood is coming, yes, we know what we get, pansystolic murmur. Point to be noted, this blood is coming to this right ventricle when this is also contracting. This is also contracting. Okay, so it is contracting, the whole blood is immediately pushed into the pulmonary artery. Right ventricle is not going to retain any blood straightaway. So that means in the very early childhood, the large amount of blood start going into the pulmonary artery. Point to be noted, in case of ASD, the blood was not able to come because this blood comes in diastole. Okay, diastole, the ventricle is stiff. It's not expanding in diastole. Stiffness means not expanding in diastole. So blood cannot come here. No blood, it cannot go further. But in here, in case of VSD, blood is coming in systole, where systole pumping is very fast. Large amount of blood will go, and that lead to increased pulmonary blood flow, and that's why in VSD, PAH occurs very fast, early as compared to ASD. Same thing in PDA also. In PDA also, blood is going like this. Oh, it has totally bypassed the ventricles also. Blood will be always flowing like this. So that's why in PDA also, the PAH occurs early as compared to ASD. So we are clear about, right? And so in these patients, they tend to develop symptoms, especially in VSD. Especially in VSD, they tend to develop the symptom very fast. Okay? So we learn the basic pathophysiology, how we diagnose the case of VSD. Echocardiography and cardiac catheterization is always the most accurate test. And what we see is step up of oxygen. Remember, here a right atrium will have a deoxygenated blood, right ventricle oxygenated, pulmonary artery oxygenated. In PDA, we learned that in PDA, we have deoxygenated, and oxygenated. And that's the advantage of going for by the catheterization studies, right? Surgery of VSD, closure is done in the large defect. Very small defects, particularly muscular. They may even close spontaneously. Why? Muscular will grow and that may close, spontaneous closure may occur, especially in the muscular variety. Well, we plan to do surgery in VSD if they fail to respond to medical therapy. Left to right shunt is more than 2:1. And there is signs of pulmonary arterial hypertension. This is once the PAH occur fully and that can lead to reversal of shunt. Now it becomes right to left shunt, so-called Eisenmenger syndrome. If in the very advanced stages PAH has occurred so high, it's going back. What do you mean by so back? Well, same holiday, large amount of vehicle going on a picnic spot, going. A stage comes, the road is jam-packed due to very high amount of vehicle traffic. Somebody comes, oh, traffic jam, let's go back. Now reverse flow will be there, Eisenmenger syndrome. But once the reversal of shunt occur, it becomes non-operable. That's why it is even in ASD also, what I told you, get operated, because sooner or later PAH will happen. So why to wait? And once the reversal of shunt means no treatment, then life doesn't last long also. So it's a doctor's duty to explain the thing very nicely. Well, now we should also have it early. So we got 3 indication of surgery. Patient may have some other complication. They include AR. Patient of VSD might have associated aortic regurgitation, infundibular stenosis, or there may be infective endocarditis. All these. So if the patient develops infective endocarditis, of course you will treat the endocarditis. Then is a high time, get operated, because endocarditis recurrence can occur, and that itself is a leading cause of mortality. How we diagnose PDA? Again, echo and Doppler study and cardiac catheterization. One thing is very clear, these patients, all these valvular heart disease, echo is always the first line treatment. And catheterization study can be done in this patient. Surgical treatment in PDA, up to 6 months spontaneous closure can occur, but after that it doesn't happen. Okay, majority of time they should be closed by preschool age, right? Should be closed up to 6 months. If it has to close by natural way, it will close, but after that if it will not close, then it's better to get in the preschool age, regardless of the symptom, whether symptom are there or not, get it operated. Same to avoid endocarditis, to avoid the ventricular heart failure, and to avoid PH. Same like VSD, we want to close it. We don't want any complication. Don't get it operated. Okay. Well, in adults also, as long as left to right shunt is there, even PAH is there, as long as left to right shunt. This is true for VSD also. So remember, indication of surgery in VSD and PDA are same. In children, you get operated to avoid the later complication. In the adults, even PAH is occurring, but left to right shunt, as long as left to right shunt is occurring, you get it operated. Even there are some early feature of PAH, but if the flow is left to right, get operated, because once right to left, it become non-operable. So friends, golden line to remember. In ASD, oxygen saturation increase in RA, RV and PA, pulmonary artery. In VSD, oxygen saturation increase in RV, PA. In PDA, only in pulmonary artery. ASD, no shunt murmur. VSD, pan-systolic murmur. PDA, continuous murmur. The golden line to remember. Thank you very much. God bless all of you.